Hi, today we will continue our discussion on heart failure, beginning with Table 15, which compares the clinical manifestations of left-sided and right-sided heart failure. Table 15, Signs and Symptoms of Left versus Right Heart Failure. Heart failure produces symptoms through two major mechanisms. Number 1, low cardiac output, forward failure. 2, venous congestion, backward failure. Low cardiac output or forward failure. Left heart failure, when the left ventricle fails, it cannot pump sufficient blood to the systemic circulation. Patients commonly present with fatigue due to poor tissue perfusion, syncope from reduced cerebral blood flow, systemic hypotension, cool extremities caused by peripheral vasoconstriction, slow capillary refill, peripheral cyanosis in severe cases. Pulsus alternans indicating severe left ventricular dysfunction, functional mitral regurgitation due to ventricular dilation, a left-sided S2 gallop reflecting increased ventricular filling pressure. Right heart failure. Forward failure on the right side usually occurs because the right ventricle cannot deliver enough blood to the lungs. Clinical findings include symptoms of left heart failure if reduced right ventricular output causes underfilling of the left ventricle, tricuspid regurgitation, and a right side S2 gallop. Venous congestion or backward failure. Backward transmission of pressure into pulmonary circulation causes pulmonary congestions. Typically, manifestations include dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea or PND, cough, bibasal crackle on lung examination. Right heart failure. Venous congestion affects the systemic circulation. Clinical findings include peripheral edema, elevated jugular venous pressure with positive abdomino-jugular reflux, Kussmaul's sign in selected conditions, hepatomegaly, pulsatile liver caused by severe tricuspid regurgitation. Table 15 is extremely important because it clearly differentiates pulmonary congestion seen in the left heart failure from systemic venous congestion seen in the right heart failure. Pathophysiology of heart failure. The most common underlying causes include ischemic heart disease, coronary artery disease, hypertension causing left ventricular hypertrophy, valvular heart disease, tachyarrhythmias. Initially, myocardial injury leads to impaired contraction or impaired ventricular filling. This triggers cardiac remodeling, which attempts to maintain cardiac output but ultimately becomes harmful. There are two major remodeling patterns. Pressure overload, examples include aortic stenosis and chronic hypertension. Pressure overload produces concentric hypertrophy where ventricular valves become thickened. Eventually, this leads to interstitial fibrosis, reduced compliance, diastolic dysfunction. Volume overload, examples include aortic insufficiency. Volume overload causes ventricular dilation known as eccentric remodeling, which progressively weakens systolic function. As remodeling progresses, forward cardiac output falls. The sympathetic nervous system becomes activated. The renin-angiotensin-aldosterone system or RAAS is activated. Sympathetic stimulation produces tachycardia, increased myocardial oxygen demand, and peripheral vasoconstriction. RAAS activation causes sodium retention, water retention, increased preload, increased afterload. Although these mechanisms initially compensate for reduced cardiac output, they eventually worsen ventricular dysfunction, increase myocardial oxygen demand, and lead to decompensated heart failure. Heart failure with reduced ejection fraction, or HFrEF. Definition: heart failure with reduced ejection fraction is defined as left ventricular ejection flow below 40%. This represents impaired myocardial contractility with reduced ejection fraction and reduced stroke volume. The typical phenotype is volume overload. Clinical findings include patients commonly have displaced apex beat, third heart sound or S3, cardiothoracic ratio greater than 0.5 on chest X-ray, reduced left ventricular ejection fraction, left ventricular dilation. Causes include ischemia, extensive coronary artery disease, previous myocardial infarction. Non-ischemic, hypertension, diabetes mellitus, alcohol toxicity, other toxins, myocarditis, dilated cardiomyopathy, and tachycardia-induced cardiomyopathy. These conditions all impair systolic contraction. Heart failure with mid-range ejection fraction, or HFmrEF. Definition: heart failure with mid-range ejection fraction, HFmrEF, is defined as left ventricular ejection fraction between 41 and 49%. This group includes patients who are recovering from heart failure with reduced ejection fraction, or HFrEF, progressing from heart failure with failure with preserved ejection fraction, HFpEF, transitioning between systolic and diastolic dysfunction. Management continues to evolve because evidence remains less robust than for HFrEF or heart failure with reserved ejection fraction. Heart failure with preserved ejection fraction. Definition: heart failure with preserved ejection fraction is defined as left ventricular ejection fraction more than 50%. This condition was previously called diastolic heart failure. The hallmark is normal systolic contraction, impaired ventricular relaxation and filling. The ventricular becomes thick, stiff, and poorly compliant. Approximately 50% of all heart failure patients have preserved ejection fraction, and their prognosis is often similar to the HFrEF and HFpEF. HFpEF is particularly common in older adults and women. Pathophysiology: reduced ventricular compliance causes increased left ventricular filling pressure, increased left atrial pressure and volume, pulmonary venous congestions, and dyspnea. Clinical findings: patients may demonstrate hypertension, sustained apex beat, fourth heart sound or S4, normal sized heart on chest X-ray, left ventricular hypertrophy on ECG or echocardiography, preserved ejection fraction. Causes: transient causes is myocardial ischemia, coronary artery disease, myocardial infarction. Permanent causes is severe hypertension, aortic stenosis, hypertrophic cardiomyopathy, restrictive cardiomyopathy such as uh, amyloidosis, previous myocardial infarction. High output heart failure. Unlike typical heart failure, the heart pumps a high cardiac output, but it is still insufficient to meet the body's increased metabolic demands. Common causes include severe anemia, thiamine deficiency or beriberi, hyperthyroidism, arteriovenous fistulas, left to right shunts, Paget's disease, renal disease, hepatic disease. Patients often have an underlying cardiac abnormality that becomes unstable to compensate for the increased circulatory demand. Precipitants of symptomatic exacerbation. Whenever a patient presents with worsening heart failure symptoms, always determine whether the deterioration represents a natural progression of the disease or a new precipitating factor. Clinicians should always search for reversible causes such as infection, myocardial ischemia, arrhythmias, uncontrolled hypertensions, medications non-adherence, excess dietary sodium, renal dysfunction. Identifying and correcting these triggers is a key component of heart failure management. The differential diagnosis or causes of worsening heart failure can be organized into several categories. Number 1, new cardiac insults. These represent new cardiac events that increase myocardial stress or reduce cardiac function. These are myocardial infarction causes sudden loss of functioning myocardium, cardiac arrhythmias, especially atrial fibrillation with the rapid ventricular response or ventricular tachyarrhythmias, progressive valvular disease such as worsening aortic stenosis or mitral regurgitation, cardiotoxic chemotherapy including anthracyclines and trastuzumab, which can impair ventricular function. Number 2, increased cardiovascular demand. Sometimes the heart itself has not deteriorated, but the body demands more cardiac output than the weakened heart can provide. Examples include hypertension, severe anemia, thyrotoxicosis, systemic infections, or sepsis. These conditions increase myocardial workload and precipitate heart failure symptoms. Number 3, medications, non-compliance. One of the most common and preventable causes of decompensation is poor adherence to medications such as diuretics, ACE inhibitors or ARNI, beta blockers, mineralocorticoid receptor antagonists. Stopping these medications often leads to fluid retention and worsening symptoms. Number 4, dietary indiscretion. Excessive sodium intake increases water retention. Patients frequently present after consuming high salt meals during holidays or social events. Number 5, obstructive sleep apnea. Repeated nocturnal hypoxia activates the sympathetic nervous system, increases pulmonary pressure, and worsens both left and right-sided heart failure. Investigations. Once heart failure is suspected, investigations serve two important goals. Number 1, confirm the diagnosis. Number 2, identify precipitating factors and reversible causes. Blood work. A comprehensive laboratory evaluation should include a complete blood count or CBC, helps to detect anemia, leukocytosis suggesting infection. Electrolytes. Electrolytes measure sodium, potassium, calcium, magnesium. Electrolyte disturbances may both cause and result from heart failure or diuretic therapy. Renal function assesses blood urea, nitrogen or BUN, and creatinine. Renal dysfunction commonly accompanies heart failure and influences medication dosing. Metabolic assessment: evaluate fasting glucose, HbA1c, lipid profile, HbA1c, lipid profile. These identify cardiovascular risk factors and diabetes. Liver function tests: congestive hepatopathy from right-sided heart failure may elevate liver enzymes. Thyroid function: measure TSH since both hypo and hyperthyroidism can worsen heart failure. Ferritin: iron deficiency is common in chronic heart failure and contributes to fatigue and reduced exercise tolerance. BNP and NT-proBNP. These biomarkers are released from ventricular myocardium in response to increased wall stretch. Brain natriuretic peptide greater than 100 picograms per milliliter. N-terminal probrain natriuretics peptide greater than 300 picograms per milliliter supports the diagnosis of heart failure. A clinical peril: BNP has a high negative predictive value. A low brain natriuretic peptide or BNP level makes heart failure unlikely. Uric acid: uric acid may be elevated due to reduced renal perfusion or diuretic therapy. Urinalysis: a screen for renal disease and proteinuria. Electrocardiogram or ECG: the ECG helps identify chamber enlargement, cardiac arrhythmias, evidence of previous or acute myocardial infarction, ischemia, conduction abnormalities. Although ECG findings are not diagnostic of heart failure, they often reveal the underlying cause. Chest X-ray: typical findings include cardiomegaly, pulmonary vascular redistributions, pleural effusions, curly B lines, bronchial alveolar cuffing, pulmonary edema. The chest X-ray is valuable for assessing pulmonary congestion. Echocardiography: this is the most important imaging study in the heart failure. It provides information about left ventricular ejection fraction or LVEF, systolic function, diastolic function, E to A ratio, chamber dimensions, regional wall motion abnormalities, valvular disease, right ventricular systolic pressure, precordial effusion. Echo distinguishes HFrEF from HFpEF guiding therapy. Radionuclide angiography provides an accurate measurement of left ventricular ejection fraction when echocardiography is technically limited. Myocardial perfusion scintigraphy or thallium or systemic SPECT. These are used to evaluate myocardial ischemia, myocardial viability, coronary artery disease. Additional diagnostic investigations when further evaluation is required. Additional studies include cardiac catheterizations, cardiopulmonary exercise testing, cardiac MRI, myocardial perfusion imaging, MUGA scan, CT scan. These investigations help define ischemia, myocardial structure, exercise capacity, and ventricular function. Acute treatment of pulmonary edema. The immediate priorities are improve oxygenation, reduce pulmonary congestion, optimize cardiac output, treat the underlying precipitating cause, always address reversible causes such as acute myocardial ischemia, arrhythmias, and hypertensive emergency. LMNOPP approach. A useful mnemonic for acute pulmonary edema management is LMNOPP. L. Lazex or furosemide, 40 to 500 milligram IV. Loop diuretics rapidly reduce intravascular volume and pulmonary congestion. M for morphine, 2 to 4 milligram IV. Morphine decreases anxiety, reduces preload through venodilation. Its use is now selective because of potential respiratory depression and hypotension. N. Nitroglycerin can be administered sublingually, intravenously, or topically. Benefits include venodilation, reduced preload, reduced myocardial oxygen demand. Use cautiously in preload-dependent patients such as right ventricular infarction, severe right-sided heart failure. O. Oxygen. Provide supplemental oxygen only for hypoxemic patients. Routine oxygen therapy is unnecessary when oxygen saturation is normal. P. Positive airway pressure. Use CPAP or BiPAP. These improve oxygenation, decrease preload, reduce work of breathing, and lower the need for intubation. P. Position. Place the patient correctly, sitting upright, legs dependent if tolerated. This reduces venous return and pulmonary congestion. Advanced ICU therapies. Patients with severe cardiogenic shock may require vasodilators such as nitroprusside or hydralazine. Sympathomimetics such as dopamine. Dose dependence effects include low dose renal vasodilation, medium dose positive inotropic effect, high dose vasoconstrictions with increased systemic vascular resistance, generally undesirable in heart failure. Dobutamine, beta-1 selective antagonists that increase contractility and improves cardiac output. Potential adverse effects include tachycardia, arrhythmias, hypotension, atrial fibrillation. Phosphodiesterase inhibitors. Examples: Miralinone produces positive inotropy, vasodilation, reduced systemic vascular resistance. Useful in selected patients with advanced heart failure. Pulmonary artery catheter. Consider in unstable patients or when the diagnosis is uncertain. A pulmonary capillary wedge pressure or PCWP more than 18 millimeters of mercury strongly suggests cardiogenic pulmonary edema. Mechanical ventilation. Mechanical ventilation required for severe respiratory failure, persistent hypoxemia, and respiratory fatigue. Rare but life-saving therapies for refractory cardiogenic shock. Intra-aortic balloon pump IABP reduces afterload and improves coronary perfusion. LVAD, RVAD ventricular assist device provide mechanical circulatory support. Cardiac transplantation, definitive therapy for the end-stage heart failure. Long-term treatment. Most evidence-based therapies applies to heart failure with the reduced ejection fraction or HFrEF. For HFpEF, no medication has consistently reduced mortality, so management focuses on treating hypertension, managing comorbidities, preventing congestions with appropriate diuretics. Conservative measures. Every patient should receive comprehensive non-pharmacologic management. These include oxygen therapy during hospitalization when indicated, bed rest during acute decompensation, elevating the head of the bed to improve breathing, lifestyle modification including regular exercise after stabilization, smoking cessation, diabetes control, reduced alcohol intake, and patient education. Sodium restrictions and appropriate fluid restrictions. Referral to multidisciplinary heart failure clinics, particularly for high-risk patients who are or those with recent hospitalization. Remember that the right margin notes are high-yield clinical pearls. BNP, secreted by ventricular myocardium in response to left ventricular stretch. BNP and NT-proBNP are valuable diagnostic biomarkers. Low BNP effectively rules out heart failure. NYHA functional classification. Class 1, no limitation of physical activity. Class 2, mild limitation with ordinary activity. Class 3, mild limitation with less than ordinary activity. And Class 4, symptoms at rest. 5 most common causes of CHF. Coronary artery disease, 60 to 70%, hypertension, idiopathic dilated cardiomyopathy, valvular heart disease, alcohol-induced cardiomyopathy. Mnemonic for heart failure precipitants. Heart failed. H stands for hypertension, E stands for endocarditis or environment, A stands for anemia, R stands for rheumatic or other valvular disease, T stands for thyrotoxicosis, F stands for failure to take medications, A stands for arrhythmiasis, I stands for infection or ischemia, L stands for lung disease such as PE, pneumonia or COPD, E stands for endocrine disorders, and D stands for dietary indiscretion. Number 1, non-pharmacological management. Before prescribing medications, remember that successful heart failure treatment always starts with lifestyle modification. According to the 2021 Canadian Cardiovascular Society or CCS guidelines, several important interventions should be recommended. First, patients should restrict sodium intake to approximately 2 to 3 grams per day. Excess dietary sodium promotes water retention, increases preload, and worsens pulmonary and peripheral edema. Second, patients should monitor their body weight every day, especially those with heart failure, fluid retention, or difficult to control congestion. A sudden increase in body weight, usually more than 2 kilograms over a few days, often represents fluid accumulation rather than fat gain and may be the earliest sign of worsening heart failure. Fluid intake should also be restricted in selected patients. Those with persistent congestion despite diuretic therapy are generally advised to limit fluids to about 2 liters per day. Finally, cardiac rehabilitation is strongly encouraged for patients with NYHA class 1 to 3. Heart failure after clinical stabilization. Structured exercise programs improve exercise capacity, reduce symptoms, and enhance quality of life, as demonstrated in HF Action Trial. Number 2, pharmacological therapy. Now let's move to the pharmacological therapy, which forms the cornerstones of heart failure treatment. ACE inhibitors and ARBs, RAS blockade. The first major drug class is ACE inhibitors. These medications inhibit the renin-angiotensin-aldosterone system, reducing afterload, limiting ventricular remodeling, slowing progression of left ventricular dysfunction, and improving survival. ACE inhibitors are recommended for all symptomatic patients with NYHA class 2 to 4 heart failure, patients with left ventricular ejection fraction below 40%, patients following myocardial infarction with reduced systolic function. If ACE inhibitors are not tolerated because of cough or angioedema, angiotensin II receptors blockers, ARBs, may be substituted. ARBs may also be added only if in selected situations. Although routine combination therapy with ACE inhibitors is not recommended because studies such as CHARM and on-target demonstrated increased risk of hyperkalemia, renal failure, dialysis requirement. Therefore, combining ACE inhibitors and ARBs should generally be avoided. Antiarrhythmic drugs. Heart failure patients frequently develop arrhythmias. Acceptable antiarrhythmic agents include amiodarone, beta blockers, digoxin. Many other antiarrhythmic medications worsen ventricular functions and should be avoided. Anticoagulants. Patients with heart failure may require anticoagulation when thromboembolic risk is high. Either direct oral anticoagulants, DUACS, or warfarin may be used. Important indications include atrial fibrillation, left ventricular thrombus, previous thromboembolic events. Routine anticoagulation is not recommended solely because a patient has heart failure. ARNI, angiotensin receptor neprilysin inhibitor. One of the most important advances in heart failure treatment is the ARNI, represented clinically by sacubitril and valsartan. This drug combines an angiotensin receptor blocker, neprilysin inhibitor. The ARB suppresses the RAAS system, while neprilysin inhibition increases endogenous natriuretic peptides producing vasodilation, natriuresis, diuresis, reduces cardiac remodeling. ARNI therapy slows progression of left ventricular dysfunction and improves survival. Current guidelines recommend switching eligible symptomatic patients from an ACE inhibitor or ARB to an ARNI if they remain NYHA class 1 to 4 with left ventricular ejection fraction below 40%. Remember that an ACE inhibitor must be stopped before 36 hours before initiating sacubitril valsartan to reduce the risk of angioedema. Beta blockers. Beta blockers are another pillar of heart failure therapy. These medications block sympathetic stimulation, reducing heart rate, myocardial oxygen demand, harmful neurohormonal activation. They improve ventricular remodeling and significantly reduce mortality. They are indicated for NYHA class 1 to 3 heart failure with reduced ejection fraction and stable class for patients. Evidence-based beta blockers include carvedilol, bisoprolol, metoprolol succinate. The COMET trial demonstrated survival benefits with carvedilol. An important teaching point is that beta blockers should be started at very low dose and increased slowly because symptoms may transiently worsen during initiation. Diuretics. Diuretics primarily improve symptoms by relieving congestion. Unlike ACE inhibitors or beta blockers, they do not significantly reduce mortality, but they dramatically improve quality of life. Common agents include furosemide, usually 40 to 500 mg once daily, depending on severity, medolazone, which may be added once weekly in resistant edema. Combining loop and thiazide type diuretics produces sequential nephron blockade, increasing diuresis. These medications help relieve dyspnea, peripheral edema, pulmonary congestion, paroxysmal nocturnal dyspnea. Electrolytes and renal functions must always be monitored. Digoxin and cardiac glycosides. Digoxin increases myocardial contractility while slowing atrioventricular nodal conduction. It improves symptoms, reduces hospitalization, does not improve overall survival. It is particularly useful in patients with heart failure plus atrial fibrillation, persistent symptoms despite standard therapy. One important clinical peril is that patients stabilized on digoxin may deteriorate if it is suddenly withdrawn. Hydralazine and isosorbide dinitrate. This combination provides both arterial and venous vasodilation. Guidelines recommend it particularly for symptomatic Black patients with HFrEF despite guideline-directed medical therapy. Patients unable to tolerate ACE inhibitors, ARBs, or RNIs because of renal dysfunction or hyperkalemia. This therapy improves both symptoms and survival in appropriate patients. Ivabradine. Ivabradine selectively inhibits the funny current, if current within the sinoatrial knot. It lowers heart rate without reducing myocardial contractility. It's recommended in patients with symptomatic HFrEF, sinus rhythm, resting heart rate above 70 beats per minute, and already receiving maximally tolerated guideline-directed medical therapy. Although effective in reducing cardiovascular hospitalization, evidence remains weaker than for ARNIs or SGLT2 inhibitors. Mineralocorticoid receptor antagonists. The final major class discussed on this page is mineralocorticoid receptor antagonists. They include spironolactone and eplerenone. These drugs block aldosterone, reducing sodium retention, fibrosis, and ventricular remodeling. They significantly reduce mortality in symptomatic heart failure with reduced ejection fraction. They are indicated for patients already receiving ACE inhibitors or ARNI, beta blockers, and loop diuretics. Because these medications can cause life-threatening hyperkalemia, potassium and renal function must be monitored carefully. Avoid initiation if serum creatinine exceeds 220 micromoles per liter and potassium exceeds 5.2 millimoles per liter. The sidebar explains the physiology of NT-proBNP. When ventricular walls stretch because of increased filling pressure, cardiomyocytes release proBNP, which is cleaved into active BNP and inactive NT-proBNP. NT-proBNP is useful for diagnosing heart failure. Values strongly suggesting heart failure are younger than 50 years, 450 picograms per milliliter. Age 50 to 75 years, more than 90 picograms per milliliters. Older than 75 years, more than 1,800 picograms per milliliter. Remember that age, obesity, renal dysfunction, and pulmonary embolism may influence NT-proBNP levels. The page provides the mnemonic HERBB to remember classic chest X-ray findings. H. Heart enlargement, cardiothoracic ratio greater than 0.5. E. Pleural effusion. R. Redistribution of pulmonary vessel. B. Kerley B lines. B. Bronchular or alveolar cuffings. These findings reflect increasing pulmonary venous congestion. Clinical pearls. The page concludes with several important guideline updates. Patients already taking beta blockers who develop acute decompensated heart failure should generally continue beta blockers unless they develop cardiogenic shock, severe pulmonary edema, hemodynamic instability. The 2021 Canadian Cardiovascular Society Heart Failure Guidelines recommend guideline-directed medical therapy or GDMT for patients with heart failure and reduced ejection fraction. Whenever possible, therapy should include the 4 foundational drug classes: ARNI or ACE inhibitors, ARB, evidence-based beta blockers, mineralocorticoid receptor antagonists, SGLT2 inhibitors. Together, these therapies substantially reduce cardiovascular mortality, heart failure hospitalizations, and improves quality of life. SGLT inhibitors in heart failure. Examples include empagliflozin, canagliflozin, dapagliflozin. Although these medications were originally developed for type 2 diabetes mellitus, research has shown that they provide significant cardiovascular benefits that extends beyond glucose control. Today, SGLT2 inhibitors are recommended for patients with a stable heart failure with reduced ejection fraction or HFrEF, regardless of whether they have diabetes. In patients who have both HFrEF and type 2 diabetes, these drugs improve symptoms while significantly reducing mortality and hospitalization for heart failure. The exact mechanisms are multifactorial and include osmotic diuresis and natriuresis, reduction in cardiac preload and afterload, improved myocardial metabolism, reduction in inflammation and fibrosis, improved renal protection. Because of these benefits, SGLT2 inhibitors have become one of the 4 foundational therapies for HFrEF. HFrEF management. The guideline directed medical therapy for heart failure with reduced ejection fraction includes 4 essential medication classes. 1. ARNI. The preferred first-line therapy is an angiotensin receptor neprilysin inhibitor, or ARNI. If the patient is already receiving an ACE inhibitor or ARB, they should generally be switched to an ARNI when appropriate. ARNIs improve survival by blocking the renin-angiotensin system, increasing beneficial natriuretic peptides, promoting vasodilation, reducing cardiac remodeling. 2. Beta blockers. Evidence-based beta blockers include bisoprolol, carvedilol, metoprolol succinate. These medications reduce sympathetic activations, slow heart rate, improve ventricular filling, prevent arrhythmias, improve survival. Patients often feel worsened initially because of reduced contractility, but long-term outcomes are significantly improved. 3. Mineralocorticoid receptors antagonists, MRAs. Examples include spironolactone and eplerenone. These medications block aldosterone, reduce sodium retention, prevents myocardial fibrosis, improve survival. Patients require regular monitoring of potassium, renal function. Number 3, mineralocorticoid receptors antagonists, MRAs. Examples include spironolactone and eplerenone. These medications block aldosterone, reduce sodium retention, prevent myocardial fibrosis, improve survival. Patients require regular monitoring of potassium and renal function because hyperkalemia is an important adverse effect. Number 4, SGLT2 inhibitors. Finally, SGLT2 inhibitors complete the 4 pillars of heart treatment. Together, these 4 medications groups dramatically reduce mortality, hospitalization, and disease progression. Heart failure with preserved ejection fraction, or HFpEF management. Management of heart failure with preserved ejection fraction differs because no therapy has shown the same mortality benefits seen in HFrEF. Treatment focuses on controlling contributing conditions. The page recommends ARB therapy. ARBs are commonly used to improve blood pressure, control and reduce ventricular stiffness. Control of hypertension. Blood pressure should be managed according to Canadian Hypertension Education Program guidelines. Proper blood pressure control decreases ventricular hypertrophy and improves symptoms. Mineralocorticoid receptor antagonists. MRAs may be considered when serum potassium is below 5 millimole per liter. Estimated GFR is greater than 30 milliliter per minute. Careful monitoring is again essential to avoid hyperkalemia. Surgical management. Medical therapy is not sufficient for every patient. Advanced heart failure may require surgical intervention. Coronary revascularization. The most common operation performed in heart failure patient is coronary revascularization. Its goal is to restore blood flow to areas of hibernating myocardium. Hibernating myocardium refers to viable heart muscles that contracts poorly because of chronic ischemia but can recover once blood flow is restored. Selected patients experience substantial improvements in ventricular function after coronary artery bypass grafting. Mitral valve surgery. Patients with ischemic left ventricular dilation frequently develop secondary mitral regurgitation. Repair or replacement of the mitral valve reduces volume overload and improves symptoms. Left ventricular remodeling surgery. Another option is surgical ventricular remodeling. Examples include Batista procedure involving partial left ventriculectomy, Door procedure involving left ventricular restoration. These operations reduce ventricular size. According to Laplace's law, reducing ventricular radius decreases wall stress, thereby improving ventricular efficiency and function. Although these procedures are performed less frequently today, understanding their physiological rationale remains important. Mechanical circulatory support. Patients with end-stage heart failure may require ventricular assist devices or VADs. These devices can be used as a bridge to transplantation, as a destination therapy, or as a bridge to recovery in selected patients. Heart transplantation. For carefully selected patients with refractory end-stage heart failure despite maximal therapy, heart transplantation remains the definitive treatment. Figure 44, ivabradine mechanisms of action. Now let's examine figure 44. Ivabradine mechanism of action, one of the most important illustrations on this page. Ivabradine is unique because it selectively lowers heart rate without reducing myocardial contractility. The figure demonstrates that ivabradine acts on the F or funny channels located within the sinoatrial knot. Normally, these channels allow slow spontaneous depolarization during phase 4, gradually bringing the pacemaker cells to threshold. Ivabradine blocks these F channels. As illustrated in figure 44, blocking the funny current slows the rate of spontaneous diastolic depolarization. Because depolarization occurs more slowly, fewer action potentials are generated, the sinoatrial knot fires less frequently, and the heart rate decreases. Importantly, blood pressure remains relatively unchanged, myocardial contractility is preserved, cardiac conduction through the AV knot is minimally affected. Clinically, slowing the heart rate increases diastolic filling time. Longer diastole improves coronary perfusion while simultaneously reducing myocardial oxygen demand. Ivabradine is therefore particularly useful in symptomatic HFrEF patients who remain tachycardiac despite maximally tolerated beta blockers therapy, especially when the patient is in sinus rhythm with a resting heart rate of at least 70 beats per minute. Procedural interventions. When symptoms persist despite optimal medical therapy, device therapy becomes important. Cardiac resynchronization therapy, or CRT. CRT improves synchronization of ventricular contraction. Candidates generally have QRS duration greater than 130 milliseconds. Left bundle branch block morphology. Left ventricular ejection fraction below 35%. Persistent symptoms despite optimal medical therapy. Patients with wider QRS complexes, especially those greater than 150 milliseconds, derive the greatest benefit. CRT improves symptoms, exercise tolerance, left ventricular remodeling, and survival. There are two forms, CRTP, which provides pacing only, and CRTD, which combines pacing with an implantable defibrillator. Implantable cardioverter defibrillator, or ICD. ICDs are primarily used for prevention of sudden cardiac death. Candidates include patients with previous myocardial infarction, left ventricular ejection fraction below approximately 30 to 35%, persistent systolic dysfunction despite optimal therapy. ICDs continuously monitor cardiac rhythm and deliver life-saving shocks when ventricular tachycardia or ventricular fibrillation occurs. LVAD and RVAD. Patients with severe heart failure may require left ventricular assist devices, LVADs. Right ventricular assist devices are RVADs. These devices provide mechanical circulatory support until transplantation or as a permanent therapy. Cardiac transplantation. Patients who remain symptomatic despite maximal medications and device therapy should be evaluated for transplantation. Valvular repair. If severe valvular disease contributes significantly to chronic heart failure, surgical valve repair or replacements should be considered because correcting the underlying lesion often leads to substantial symptomatic improvement. To summarize today's lectures, we start with the table 15, which distinguishes the signs and symptoms of left versus right heart failure, separating forward failure from backward congestion. Heart failure develops through myocardial injury, cardiac remodeling, and activation of the SNS and RAS. Heart failure with reduced ejection fraction, or HFrEF, is left ventricular ejection fraction below 40%, is characterized by impaired systolic function and ventricular dilation. Heart failure with mid-range ejection fraction, HFmrEF. It means left ventricular ejection fraction between 41 to 49%, represents an intermediate phenotype. Heart failure with preserved ejection fraction, HFpF, it means left ventricular ejection fraction more than 50%, is characterized by preserved systolic function with impaired ventricular relaxation. High output heart failure occurs when metabolic demands exceeds even an elevated cardiac output. Always evaluate patients with worsening heart failure for reversible precipitating factors, as treating the underlying triggers can significantly improve outcomes. The most common causes of right-sided heart failure is left-sided heart failure. Heart failure management requires a combination of lifestyle modification and evidence-based pharmacological therapy. Modern treatment focuses on 4 foundational drugs classes: ARNI or ACEI ARBs, beta blockers, mineralocorticoids receptor antagonists, and SGLT2 inhibitors, supplemented with diuretics for symptom control and additional therapies such as ivabradine, digoxin, hydralazine, isosorbide dinitrate, or anticoagulation when clinically indicated. Regular monitoring of body weight, renal function, potassium levels, and biomarkers such as NT-proBNP is essential for optimizing outcomes and preventing heart failure progression. The 4 pillars of heart failure with reduced ejection fraction treatments are ARNI, beta blockers, MRAs, and SGLT2 inhibitors. Heart failure with preserved ejection fraction management emphasizes treatment of hypertension, ARB therapy, and careful patient selection by MRAs. Surgical options include revascularization, mitral valve surgery, ventricular remodeling, ventricular assist devices, and heart transplantation. Figure 44 demonstrates how ivabradine selectively blocks the sinoatrial node if channels, slowing phase 4 depolarization and reducing heart rate without decreasing myocardial contractility. Advanced heart failure frequently requires device therapy such as CRT, ICDs, or LVADs, with transplantation reserved for carefully selected patients with end-stage disease. Thank you for attending this lecture. So if you're new to the channel, don't forget to like and subscribe and press the bell icon. See you in the next lectures.